good morning, everyone. This is another episode of Prostate Cancer Prostate Disease Podcast. We will talk a little bit about short-term versus long-term androgen deprivation treatment with high-risk localized prostate cancer. So please, Dr. Ravi, introduce yourself and tell us a little bit more of your duties and where you practice.
Yes, thank you, Ricardo. So I'm Ravi. I'm a medical oncologist and assistant professor at Dana-Farber Cancer Institute in Boston. Thank you for inviting me to the podcast. We published this paper about short versus long-term hormone therapy with radiotherapy in high-risk disease to see whether some of the work that we had done earlier using clinical risk factors could determine the benefit between long and short-term hormone therapy. As you probably know, or as everyone will know, high-risk prostate cancer, this one standard of care is radiotherapy with long-term hormone therapy, which is defined as anywhere between 18 to 36 months by clinical trials. A few months ago in European Urology, or last year now, in European Urology, we looked at the ICECAP database. The ICECAP database is basically this repository of individual patient data from randomized trials, many randomized trials in localized disease, which has actually been used to confirm the surrogacy of metastasis-free survival for overall survival in localized disease. What we did a year ago was, using that database, we showed the simple prognostic value of the number of high-risk factors has in high-risk disease patients getting radiotherapy and long-term hormone therapy. We showed that patients with one high-risk factor compared to 2 or 3 or clinical node positive, the outcomes were very different. And in this study, we sought to see whether this simple clinical risk stratification within high-risk disease, having one high-risk factor or 2 to 3 or N1, could identify benefit of long versus short-term hormone therapy with radiotherapy.
Okay, very good. But tell me something. What are the good things about the database you used, and what are the limitations of the database? We have people all around the world that hear our podcasts. So, can you tell us something more about this database and which are actually the good parts of the database and the limitations?
Yeah. So the ICECAP was set up. ICECAP stands for Intermediate Clinical Endpoints in Cancer of the Prostate. It was set up more than a decade ago by my colleague Chris Sweeney, along with Wanling Shea. When Chris was at Dana-Farber, Wanling is still at Dana-Farber. And it basically set out to collate data from randomized trials and see whether there was an intermediate endpoint that could be used in clinical trials in localized prostate cancer. Because at that time, overall survival was kind of the gold standard endpoint. And they collated individual data from many randomized trials, typically cooperative group trials, from the EURTC, RTOG, MRC, the Australian cooperative groups, other randomized studies. And they basically showed in a publication in 2017, and then subsequently validated 2024, that MFS, metastasis-free survival, was a surrogate for overall survival in localized disease. So that database has data from more than 40 randomized trials, surgical trials, radiotherapy trials, but all in localized disease. And it provides a very rich resource because you have granular individual patient data from all these trials, so you can use it to answer questions potentially that you would not be able to do with just one trial or 2 trials, which may not have sufficient power or numbers to answer questions like this.
And do you think that heterogeneity of this database is a problem, or is it a pretty homogeneous database?
The trials are obviously different. There are surgical trials, there's radiation trials. Some of the radiation trials have, no hormone therapy. Some of them have short-term, some of them long-term. Clearly, there is heterogeneity there. But broadly speaking, you can, for studies like this, we looked at a specific subset of trials within that database, so that we can make them as homogeneous as possible. And the analyses that we do correct, control for some of the variables that we can control for, like the year of randomization or the trial or the, some of the other, clinical variables at baseline. So yes, it is heterogeneous. The trial is heterogeneous, but broadly speaking, they're in a specific disease state that we're focused on, within that.
So to be practical, especially for residents, so you made a distinction between high risk and very high risk groups, right? So
Exactly.
what should you recommend for a high risk group, and what would you recommend for a very high risk group? Would you recommend more short term or long term, so that people are giving us a direct message from your clinical?
Yeah, so the paper, the message is that we were not able to conclusively show that, the hypothesis was that if you are high risk, maybe short term is sufficient and long term could be, does not add extra value. And if you're very high risk, maybe that's where you need the long term. Now, our data did not conclusively prove that. We saw evidence of a better or greater benefit from long term in the very high risk compared to high risk, but statistically the interaction was not significant, so we cannot conclude that high risk should get short term and very high risk get long term. The standard of care should be that both high risk and very high risk get long term, but there was some signal in our data that perhaps could be explored in further work in ongoing trials, particularly when we're doing intensified trials as well, to explore this clinical risk stratification further.
Okay, very good. So now we're going to the hot part of the podcast. So I want to know what are your thoughts, meaning that what do you think will change in the next years with the introduction of new imaging techniques and the new. Actually, do you think that this will still be the case in the next years with the introduction of also the new treatments and new emerging treatments? We are seeing that all the new artists are just are being used in an early stage of disease. So how do you think this will change a little bit? And also that we have some trials that are trying to avoid classic androgen deprivation therapy. So how do you see as an oncologist, especially for urologists that are hearing us, it's not that clear. You have the whole panorama, and I suppose that at your clinic you have a lot of clinical trials ongoing. So I think that your opinion can enlighten us a little bit more on what may be the near future, or just what you think about it, because we're just in the middle of the field right now.
Yeah, I think there's two big things that are going to change things. Number one is PSMA PET, which has already changed things in terms of more accurate staging, particularly of high-risk patients. And the second is the ARPIs, androgen pathway inhibitors like abiraterone, enzalutamide, darolutamide, apalutamide, how they will come into localized disease. I'll start with PSMA PET. I think PSMA PET is completely, is changing our practice in the clinic. We stage patients, we find microscopic, maybe nodal disease, maybe even microscopic metastatic disease, and we change practice. And generally speaking, the high-risk patients that we are seeing who are getting PSMA PET, there is a trend towards less surgery because you are finding isolated small pelvic lymph nodes, and everyone is uncomfortable or more uncomfortable doing surgery. So I'm definitely seeing that the practice is changing towards more radiotherapy and hormone therapy, because we find some small pelvic lymph nodes, 3-4 millimeters, and no one knows what to do with it, and we shouldn't be changing practice. But when you do the scan, it's hard to unsee it. Whether that's correct or not, I don't know, and I think that's where we that's what we're seeing in practice. The other thing with PSMA PET is the endpoint determination of metastasis or recurrence. The trials that were done in the past in ICECAP, and ICECAPs showed the surrogacy of MFS for overall survival is with conventional scans, CT, bone scan, MRI. Now with PET scans, we see recurrence and we see something on the scan when we wouldn't otherwise. We see a lymph node that is less than a centimeter, or we see a small, non-measurable lesion elsewhere, and we're calling that metastasis or recurrence, and that is being counted as events in ongoing trials. Is that really the biologic significance of a PET positive, conventional imaging negative patient or recurrence is unclear. We don't know. So I think PET, we need to collect that data on PET in the ongoing high-risk, trials when we're following patients now with PET scans, because that is the standard, to see what that long-term, what is the long-term impact of that? Does that really portend for more aggressive biology?
Sounds like bad news for urologists. Sounds like
I hate to say it. I think I know you can, in your practice as well, we stage patients, we see small lymph nodes, particularly in areas which may be outside the standard pelvic nodal template, pre-sacral area. Those patients, are getting more towards radiation. And moreover, there is now a lot of data emerging for radiation plus hormone therapy plus minus the ARPIs in that setting. The STAMPEDE trial already showed adding abiraterone for 2 years to ADT and radiotherapy in a very, very high-risk patient, was better than radiotherapy and hormone therapy alone. And that's a level 1, evidence. So when you have that, particularly for the very high-risk patient, it's hard to argue against that. And we're going to have more trials coming out with enzalutamide, the other ARPIs, in the high-risk setting. And I think very likely will show benefit for those. But we have to carefully see who are the patients who are benefiting. That's where a paper like this, which we are publishing in Prostate Cancer, Prostatic Diseases, that's where it's going to, be good to look at, well, which are the patients who are really benefiting? Are the patients with high-risk disease compared to very high-risk disease? Is there a difference in the benefit from these intensified treatments?
And do you think that also, because many people are arguing that actually PSMA PET has also this power, like detecting what is really a significant disease? So there's many authors are arguing to combine MRI with PSMA PET because maybe that's a biological active disease. So probably this is a great opportunity to know better the biological nature of what we're treating, together with all the genetic testing. So we think that we are getting there to a personalized treatment. Do you think that we're almost there, or where are the gaps that we have to fill before getting to a truly personalized medicine?
I don't know if we are there yet. I think there's still a lot of unanswered questions with PET. Right now we know that PET changes management, but the fundamental question is, does that change in management lead to better outcomes? Like, that is the question which we do not know. Where, trials like ProPSMA trial, we'll need the long-term data which are emerging. Like, does that change in management lead to a better outcome? And it's hard to do a trial now without PET. You will never really answer that question unless you have, no PET scan in one of the control arms. But that will never happen because, as they say, the train has left the station. Now we just have to interpret the findings, interpret these trials, look at the data really carefully. In high-risk disease, if they've got isolated metastatic disease outside of the pelvis that is less than a centimeter on PET, I would argue they would still benefit from local therapy. We don't know what that biologic significance is, but the practice is so varied. It's going to be hard. And it's about clinical judgment, and it's about seeing, does PET recurrence really correlate with bad biology or not? Does it actually portend for worse outcomes? And as I was saying, does that change in management that you did, does that lead to a better outcome? Which we won't know for the next few years because PET scans have only been around for 5 years, 5+ years, at least in US and Europe. And as you know, prostate cancer is a disease with a long runway. So that survival data, that long-term data will take another 5-10 years to come.
And how do you think, I'll ask you something that it's a little bit biased what we're talking about, but do you think that actually AI can help us a little bit to manage all this big data we're getting? Because we're getting trials and trials and trials, so it's not easy to follow everything, and also to summarize or combine data. It's becoming very, very difficult to also to see the differences. Classic statistical measures or analysis are not enough. So how do you see the role of AI to help us a little bit to manage this big data that we're getting? As you said, your database is one of the examples, I think, of big data being used with great results and answering all these questions that we have still there unanswered.
Yeah, I mean, I don't know much about AI. I'm not an expert by any means, but when you have large data sets, you need something that's, that's powerful enough to recognize patterns, to be able to train that, for example, for, looking at PSA trends, right? To give you an example, like in clinic now, let's say patients getting radiotherapy and hormone therapy, the definition of recurrence is the PSA nadir plus 2 by Phoenix criteria. Nowadays with PET scans, we're doing PET scans before that, and we're finding probably lesions that are there. Could we use AI to come up with some kind of better recurrence definition, by analyzing all these decades of trials, PSA follow-ups, to pick out, is there a better recurrence definition? Maybe. I mean, AI is already coming into practice. There is digital pathology AI with, the digital pathology tools, Artera, especially, which are, showing some promising results in differentiating benefit from hormone therapy in high-risk disease, or in hormone therapy for intermediate risk disease. Now, actually, this was kind of related to our study. We wanted to see, could clinical risk factors do the same as the Artera test? And actually, in the RTOG data set that we had, the clinical risk factors showed very similar result to Artera, what has been presented with Artera in ASCO 2023. So that's where I think, AI is helpful, but we will need to really validate that in larger data sets, external data sets, and in prospective studies before we can use something like Artera, which is digital pathology, to guide routine practice.
Okay, so just to give an overall of to summarize a little bit what we've been through for the ones that are hearing. So, in your opinion, right now, would you recommend in high-risk patients overall to go for short-term ADT, or are you more convinced for a long-term ADT?
I think long-term is the standard of care. I mean, I think outside of a trial, that's what I would recommend. High risk would be long-term with radiotherapy.
Okay, and the second thing is, what do you think that are the areas to prioritize right now? If you could design a study, what's the first thing you want an answer to? So what's your opinion? Something that you really need right now to actually manage patients, something that in your clinical practice is really lacking in the everyday clinical practice.
I think that's, a lot of the questions have been answered or are being answered. I think the role of neoadjuvant therapy before surgery, I think that is a very, very hot topic in high-risk disease. The Proteus trial is going to be reporting very soon. And I think that could really change the field. That is an area of active interest of mine as well. If that trial shows positive results, that really changes things. And then, that could really be a lot, really spawn much more work in that space. Because we know that hormone therapy, long-term hormone therapy with the ARPIs works with radiotherapy. If we show similar results with surgery, that could really change things, and we could move towards how we treat breast cancer, where the standard is you get neoadjuvant, then surgery, then depending on the response at surgery, you get more or less. So could we adopt a similar paradigm to that in prostate? We wait to see. But I think that's like a major area of investigation, and that could really transform, change practice. And I think the other area is personalizing duration of hormone therapy with radiotherapy, or with hormone therapy plus the ARPIs. Like, does everyone with high-risk disease need 18 to 24 months? Could we use clinical risk stratification? Could we use the AI pathology, digital classifiers? I think those are where we need to spend our efforts, and those trials are ongoing. I'm aware of trials looking at, using some baseline biomarker to say maybe you need less or more hormone therapy, so that rather than everyone getting 2 years, we can personalize duration potentially, or personalize intensification.
I think that we've gone through the main messages of this important topic. I think residents will have a clearer view, and people that hear us will really enjoy this deep insights into the complex actually management of high-risk disease, because probably in low-risk disease, we have an easier way. But when we have a high risk patients, we're always we don't know how to manage actually side effects and maximize treatment, and also the sequential treatment is very difficult. So I really thank you for your valuable time. I hope that you will consider our journal for future manuscripts of this quality. So I'll give you the last words to conclude on the main aspects you want to highlight to conclude this podcast. And thank you again for participating in our podcast series.
No, thank you for inviting me. It was a great pleasure to publish this manuscript. I think you hit the nail on the head. High-risk diseases requires multidisciplinary team input: surgery, medical oncology, radiation oncology, nuclear medicine. And I think that's where the field is going. And we have lots of questions to answer and lots of work to be done to kind of optimize and personalize the treatment for every patient, because high-risk disease is where you have the opportunity to cure patients. So if we can do better there, you can change the long-term trajectory of prostate cancer overall outcomes.
Okay, thank you very much. It was another episode of Prostate Cancer Prostate Disease Podcast, and thank you thank you to all our followers who follow interesting podcast series. Thank you.